why you joined. We love to see it. And thanks everyone for our month joining our monthly community forum. If you haven't been here before, this is a group of folks who come together each month to talk about what's new and exciting and useful and challenging and hard around breast cancer and breast health. And we're excited to see many of you here today. And it's Breast Cancer Awareness Month. So I'm sure many of you have been attending lots of events, and we appreciate you joining this one. And it's a good time each year for us to remind ourselves what we need to be thinking about in breast health, getting updated on what's latest, raising money and awareness around the disease. So thanks everyone for being here. Going through. So yeah, thanks, Allison. So the reason we've come together, the reason we do these forums, and the reason for the wisdom study in a lot of ways is the central mission of moving together towards equity and better outcomes in breast cancer for everyone. We know that breast cancer disease is a disease that touches so many. Many folks on this call have been touched by breast cancer, and we all want to make a difference and change that. And we also know that who gets breast cancer and the outcomes of those breast cancer are not equal across all groups and populations. If you want to keep going through the slides, we also know that not every and breast cancer isn't just one disease. Some people are getting really aggressive disease, some are not. Some people have diseases that are really well treated and managed. Others have more challenging times, and we don't fully understand who gets breast cancer and why. For a long time, it was really centered on family history as the key driver. But we know that's just one piece of the puzzle. So we need more research and more information to try to learn about who's getting breast cancer, how we can understand who's going to get breast cancer, screen effectively, and treat breast cancer. So we've been doing these forums for almost a year now, I think, actually, which is really exciting. Was that our first one? I think was just around this time last year. So thanks for being here for sort of our first year of these forums. And we've covered a lot of different topics. We've talked about breast cancer in the Black community. We've talked about who's at risk and knowing your risk for breast cancer, about things related to breast density, about clinical trials. We've talked a lot about genetics and different genetic components of breast cancer. Done a little series on breast cancer sort of across the lifespan, talking about breast cancer for younger women, breast cancer in midlife. And we just recently had a session on breast cancer and menopause. And our sort of theme or our overall goal for this month is what you need to know about breast health, what sort of everyone needs to know, and how to advocate for yourself, how to learn things, who to go to, what to do with that knowledge, and how to advocate for yourself as you're seeking care. So our plan for the day, we have two great speakers who are joining us, although I think maybe one speaker isn't on. We have both first speakers on yet? Not quite, hopefully. Oh yes, I see the name, great. So we have two great speakers who are joining us today, but we really want to hear from you. We want this to be a conversation. So please, as things come up, feel free to put questions in the chat. You can raise your virtual hand or your actual hand, waving frantically. Hopefully someone will see it, and speak up. Let us know what you think we should know, what questions you have, what else we should be thinking about. If you're not speaking, if you can mute yourself just for background noise, that's really helpful. We are recording this session. We record them so that we can share them with others who couldn't be here today. If you have a question you don't want anyone to see or to know it's you, feel free, you can send it directly to me or to one of the people named the wisdom study in the chat, and we can ask it. Not attached to you if you don't want to be recorded for some reason. And we're going to do a survey at the end to get your feedback on these forums, as well as hear what else you want to know about. So please make sure you're letting us know what else we can talk about in these sessions and other things we should know. All right, so we're going to dive in. So I'm just going to start first with introducing our discussants for today. So first we have Dr. Laura Esserman, who really needs no introduction. She's the director of the UCSF Breast Care Center. She's a breast surgeon and the principal investigator for the Wisdom Study. And then we're joined by the amazing Janae Harper, or Z, who is a patient care navigator. She works with Emoja Health. She's the chairwoman for the Alameda County Public Health Commission. And you have a new position, Z, with UCSF in the Office of Community Engagement. And I don't know your title, so I'm hoping you will tell us what your title is. I don't know if you want to share that right now. What's your new position?
I am fortunate and blessed. I am a community health educator.
Community health educator. So we're so grateful to have you with us today, to have both these panelists to talk about some of the ins and outs of breast health, what we need to know, and how everyone can best advocate for themselves and others in this space. So let's start with a couple topics, a couple overview. So I don't know, Laura, if you want to start us off. We wanted to just start with sort of knowing your body, knowing your breasts. What do folks need to know?
Sure, I thought that this was an important message. This came up on a recent panel that I was on where I had heard a lot of stories about people going in and saying they thought they felt something and they asked for a mammogram um, and they were told that they were too young or they couldn't have it or this, that, or the other. And, some people continued to advocate for themselves and some people didn't. And I thought it would be really important just to make sure that people know that I really recommend that one of the most important things you can do to take care of your health is to know your body. Just be familiar. You don't have to know every nook and cranny and everything, but in general, kind of be aware. Be aware if there's changes. You don't have to freak out over every little change, and you don't have to worry if you find something lumpy or bumpy in your breast, because breasts are lumpy bumpy. But if you know that this is routinely about how your body feels, if there's a change, no one will know it better than you. I think that actually in the United Kingdom, when I was there in the 90s, they actually, I thought, developed this, what I thought was a great strategy, which was be breast aware. It was right around the time that there were these studies being testing whether people should do self-breast exam. We were teaching people to do this 30-minute exam and know what everything was, which turned out to be a disaster. And everyone came in with every little lump and bump that made people crazy. And it turned out not to be that helpful, right? And so instead, what they said is just be aware. Know what your body looks like, know how it feels. I always say, like, once a month, you can do a good breast exam in 2 minutes, probably 30 seconds, really. Before you get in the shower, look at yourself, put your hands on your hips, put your arms up and arms out, and just look to see, does something pull in? Does it dimple like it didn't before? And, just put your hand up and down, up and down, up and down, up and down with one arm raised. Literally, it could take 30 seconds to do all that, just to know what's going on. And if there is something there that feels really different, check the other side. If it feels exactly the same as the other side, you don't have to worry so much about it. I always say that's why we got two of things, so you can compare one to the other. Breasts are lumpy bumpy. Some people's are fatty. Some people's are like granola, the seeds, and some, it's just, that's what they feel like. But if you feel a big mass that was not there before, it could be a cyst, it could be a cancer. You don't know. Go in and get it checked out. Now, nipple discharge, we used to really worry about that a lot, but it turns out that, once you've breastfed, especially, discharge is common, especially if you're squeezing your nipples or you have sexual activity. It's very common. If stuff is dripping out of your breast or staining your bra, that's a different story, especially if there's a change in shape. And, if you see like your breast sort of looking like an orange peel and all of a sudden looking really big, that's important to go in. And, it doesn't matter whether you had a mammogram recently or even a year ago, whether it's normal or not normal. If there's something that's different, you got to go in. That's the most important symptom to go in, right? So if there's like a puckering or a mass that's bigger, or the breast just suddenly looks bigger, get someone to check it out. And well, I always know that when patients tell me they've noticed a change, I always take that seriously, because I know they are the most likely to know. 50% of women find their own breast cancers. And again, this is one of the reasons why we're doing the wisdom study, is that we think that one size doesn't fit all. There's some people who are extremely low risk, some people who are really at high risk, and they probably don't even know it. These are things that we can find out with simple kinds of tests and simple ways to find out, and do more for the people that need it and less for the people that don't. And so I also know that over time, we haven't done as good a job of finding these fast growing cancers, because they usually show up between screens. And that's one of the things that we're after, is how do we start predicting who's at risk for fast growing versus slow growing. The slow growing cancers, we actually have, if you're really at high risk for that, we can do more than just screen you. We can actually do things to prevent breast cancer. And, there's
I'm just gonna just pause just for a sec, Laura, because we're gonna get to screening more in a second. But I did just want to ask a couple questions. V, are you still there? We lost your video. But I want to make sure you're still there. Yeah, I was just hoping, so I think Dr. Esterman said so importantly that if you see, if something's weird or something different, you need to go in. It doesn't matter if you had a clean mammogram, whatever. But I know I've heard stories, I'm assuming you might have heard stories of people who their doctor dismissed it. It's nothing, it's fine, don't worry. I'm wondering if you could talk a little bit about who should you go see, or what information should you have? What do you need to know when you're calling your doctor and saying, hey, something weird is going on with my boobs? What's the next step? Both of you, but what should people be saying or knowing or doing at that phase?
Well, in the system that I work in, what will happen, just in accordance to workflow, is they would see their primary care physician first. And then upon further examination, the primary care physician would then refer them into the breast clinic. They would go into, have their screenings, and if something looks abnormal, what have you, they would go into the breast clinic. But if you're a patient that doesn't have a primary care physician, then you go the other route. Now you're stuck in the emergency room. And then you're trying to explain to an emergency physician what you're feeling. And then you have to try and hope to get a referral immediately and to radiology to do additional screenings. So there's a variance to it. I feel like one of the pieces is how comfortable patients are in self-advocacy, especially when you are in a safety net institution, especially depending on, in addition to your socioeconomic status, and then in addition to your race, in addition to how well or how poorly the hospital is resourced. And I'm talking about just even staff, because that's a real consideration. A lot of times people don't understand that bandwidth within any hospital system can really be a horrendous barrier to care, because there aren't enough people to help. And people don't see that in the background, and hospitals, we're not going to disclose it. We're not going to tell you that the reason why you had to wait an additional 3 weeks to get your screening is because we don't have anybody in that position. That's not going to happen. So despite your attempts and you're engaging in self-advocacy, there are some things that you're just not going to be able to overcome. And I hate to say it, and it's not to be negative, but it just is what it is. And I think that,
but I want to say, Z, one of the things that's important though is it's a fortunate thing, even in the worst case scenario, if you wind up having a cancer, it's not an emergency where if you don't get something done this week, you're going to die because you didn't go in time. If a month goes by, even 2 months goes by, it's not going to be, that's not going to make the difference. It's if 6, 8, 12, 18 months go by. That's when you really get into trouble. So the thing to learn is, even so, one thing is, and I want to say, the emergency room is a terrible place to go if you have something that's wrong. It's a terrible place. Now, then you have to think about, well, what are my resources? How do I advocate for myself? And how do I get a primary care? And so, Z, if someone wants to get a primary care and they don't have a primary care, and they don't have, okay, let's take someone who doesn't have insurance. What should they do?
Well, the first thing they should do, they should check to find out if there's someone at the hospital system that can assist them with a financial appointment that can help them. And they should really know about BCCPP, which is the Breast Cancer Cervical Treatment Plan, and it is specific to breast cancer. There's also the Every Woman Counts program, which covers the testing, the screening. So you don't even have to have a cancerous diagnosis. It's actually to assist you with getting the proper screening that you need until a diagnosis is affirmed. But just to go back for a second, the thing about self-advocacy, there are two different perspectives. God be with them, and those 3 to 4 weeks or whatever that it took for them to get that appointment and everything is fine, that's one perspective. But from the patient's perspective, that it took that long despite their advocacy is why a lot of patients don't engage. And then they just wait for the system to give them what they get.
So I want to make a point that was one of the reasons I brought that up. If you think something's wrong, you make sure you advocate. And if it takes you 3 weeks, that's not the end of the world. The most important thing is you're getting it. If you've got it in 3 or 4 weeks, that's okay. Just don't give up. And say, oh my gosh, no one's listening to me. Push and push. I think what happens is, okay, say someone's 38 and they're not 40 and they're not part of, okay, screening every year starting at 40 or whatever it is. Someone says, oh, you don't need a mammogram, you're too young. We heard that the other night, right? You're too young. And you say, well, actually, I have a mass. I need this to be evaluated. And so I think it's really, and even though I know it's anxiety provoking, it's don't give up though. And don't feel like, wow, if I don't get this done in the next week or two, gosh, my whole life is on the line. It's not. Just persist until someone identifies it. And if you've got something that's new, that's messy, and it's soft and squishy, chances are it's a cyst. But if there is something new, and that's quite a bit, that's benign, that's nothing to worry about. But if you do have this hard mass, what I don't want people to do is be dismissed by someone who says, oh, you're too young, or that can't happen, or whatever. If you know your body and you think there is something that's different, don't be afraid to say, you know what? I know there's something here and it's different. I need to get it evaluated. And we heard all these stories about people who just weren't taken seriously. And I think it's also, if you are at a county hospital or you're at a place, if you feel like you're being put down because of your race, because you're a woman, because you're Latino, or because, someone's just not listening to you, you just have to remember, you know what? This is what I am supposed to do. I am supposed to be advocating for myself, and I'm not going to pay attention to them. And if they don't like it, too bad. I'm going to push until I get the care that I need. But the things you can ask for are to say, look, I know there's something here that didn't used to be here. I need either, what are the kinds of tests you can get? And people say, oh, well, you're too young for a screening. You say, well, I'm not asking for a screening. I'm asking for a workup. I'm asking for it. Like the medical term is a diagnostic mammogram. It's like, but say like, I should have, some kind of imaging test, something to take a look at this, because I'm presenting with a symptom. I'm presenting with a symptom. So it's not that I'm asking for a screening. I'm asking you to evaluate this mass. And there are all kinds of things that people can do, right? There's an ultrasound, a biopsy, there are things like that. That's what I think this is just one of the pieces. I was really struck by the film from the Tiger Lily Foundation and some of the others that were really, or Ricky Fairley's group, where, so many, African-American women were telling their story that they were ignored and told that they didn't have anything wrong. They were too young. They couldn't have it. Breast cancer is not common when you're young, but it can happen to you when you're young. And that's why people need to know. I just got a text from someone who was in town and wanted to see me because it was the 25th year anniversary of her breast cancer treatment, and also her 25th anniversary to her husband. Because I always tell people, do something that you would never have done before and use that at the end to celebrate. And she came back in the next week. She was 29. She said, okay, I decided what I'm going to do. I said, what's that? She goes, we decided to get married.
That's awesome.
Went to the justice of the peace and get married anyway. So it was, but she was 29 and she had this huge, she was Latina. She had this huge mass on the side under her arm, big nodes involved, and she was ignored. And she didn't herself think, oh, she didn't know. She said, so who gets breast cancer at 29? And no one worked her up. These are the things that we just want people to know. It's not that it's common, and you don't have to be so afraid of it all the time. But when you feel something that's clearly doesn't belong there, you've got to advocate until someone does something for you. And you have to feel like you belong here and you deserve the attention.
That is all absolutely true, and it's effective. But for what I've seen, we have to instill not just the education to know, but the confidence. Because if you're dealing with a populace that may have a lower literacy level, that's something else. Advocacy is something that I believe people should be taught. Because if we don't teach people how to advocate for themselves in a way in which they're not going to inadvertently or sometimes even intentionally be stereotyped as being angry.
Yep.
Because these are real considerations. It's not to diminish the importance of advocacy, but there are various ways in which we advocate, and there are various ways in which that advocacy is received, perceived, and which it is followed up on. And I'm just speaking from my experience being in a safety net institution, and working with a lot of safety net patients, not specific to us an institution. The stories are oftentimes the same. So the more that you teach before there is a diagnosis, just as an investment in community, so that irregardless, they know how to advocate for themselves. They walk in with a sense of empowerment because they can communicate with their physician to an extent. Especially if you're dealing with patients that may have comorbidities, where some of the symptoms that they're feeling could actually be what they associate with them having something else. So it can get very complex for people that are already overwhelmed and are filled with anxiety. So I would say, as a self-advocate, ask for help too. Is there someone else here who I can speak with that can help me with this? Because that is really a form of self-advocacy. They may have a navigation program. We don't know. Someone that can help.
Or is there, I understand you're busy. Is there somewhere else I can go? Is there
exactly.
a clinic?
So
is there a nurse? And I'm worried about this, and I've been told by experts in the field that if I feel something wrong, I need to ask for it. So we understand you may be busy. Tell me another place I can go. Where's the breast imaging center? Where's the breast surgery center?
Yes.
You know,
yes,
right?
Exactly. Because that really is self-advocacy. And I think that sometimes patients feel like self-advocacy means just talking about their condition and not asking for other places they can go, other places that may be able to assist them, or other people that they can speak with, maybe even within that particular place that they've gone to. So it's just, advocacy means different things to different people. And I feel like if we position ourselves to try to meet them where they are and try to have that assistance available, even if it's just teaching them beforehand as an investment, in terms of health education, I believe self-advocacy should be a great part of
right. And
preventative.
Right. This is so great. And I think what we're raising are some interesting, so first I just want to highlight, and I think Z's describing this so well, that this is a structural problem. People are structurally prohibited, especially people with marginalized identity, from advocating for yourself, right? You can be labeled in ways that can end up in your medical record. You can be seen as doctor shopping. You can be perceived to be drug seeking. There can be, security can be called on you if you're seen as aggressive. So there are structural reasons why it's hard for people to advocate. But I think you're both raising is some of keywords and language and questions to ask. And so things I heard were, I have a symptom. I want a diagnostic mammogram, not a screening mammogram. Somebody in the chat was already asking if that slide that showed all the things you should look for with your breast, can they have that? Can I know exactly what the language is? So I could say I had discharge, I had inverted, whatever. So we'll make sure we share that people can know. I think this idea, do you have a navigation program, or who else should I talk to if this isn't the right place? The ER is not the right place. Where should I go? Are there other questions like that? Are there other keywords or questions that people should be armed with, or tell their loved ones, this is what you should say if you're in this scenario?
So it's a really good point, Jen. And I would say, if you've got a breast problem, you almost never want to go to the emergency room, because I can tell
you never want to go to the ER for anything.
Nobody in the emergency room is going to know anything about breast cancer. There are no mammograms, or there's nothing really to do there. I've never ever seen this be of help. So, and the thing is, you can go to an urgent care. You can go to, if you don't, there are these pop-up boxes of urgent care that are, affordable. They're, they're not zero cost, but there are some, or if, even if you go and you don't have insurance of any kind and you want to go to the safety net hospitals, he was saying, you can say, look, and, one of the things I heard in some of these discussions is I asked for a screening mammogram. Don't ask for a screening mammogram. Say, I have a mass. This is new. I am concerned this was not there before. This is a symptom that could be breast cancer. And I know that I'm supposed to work this up. Just, we're trying to give you some words to say that. And as he said, then again, well, we're not here. Okay, well, where else? Tell me where else I should go. Where is there a breast clinic here? Is there an imaging center? Is there a biopsy center? Tell me where to go. And, be patient. Don't be frustrated, because you really, 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 if you have something that's wrong, if you wake up and your nipple's pulled in and it wasn't there before, or it's big and red, or there's something wrong, those are the things you definitely want to go in for.
And if the patient is aware, if they have a family history of breast cancer, that's something that, sometimes it may help and say, I'm really concerned as there is a history of breast cancer in my family. I have this happening. So you just, again, it's, there's no, for me, there's no right or wrong way to advocate. There are just various ways to advocate, just depending. That's what I would say.
Yeah, we want to give you the power to know
Mhm.
it's okay to ask, right?
And that was a great segue that you mentioned family history into talking about risk factors. So maybe Laura, you want to talk a little bit about some of the risk factors?
So there are a bunch of risk factors for breast cancer, but remember, people also have breast cancer without risk factors. So again, if you have a symptom, don't say, "Oh, I don't have it in my family. I do everything right. I'm eating right. That's it. It couldn't happen to me. It can't. It happens to 1 in 8 women. So it is common. But there are things that make you more susceptible. A lot of people don't know their family history. It's important to ask. If you have relatives, especially mother, aunt, sister, who had breast cancer at a young age, that might indicate that you have inherited a predisposition to breast cancer where you're more at risk. So it's good just to talk about it with your family members because it's a way to educate all of them as well. There are some things, that they're the kind of what we call our internal environment exposure, like when you start your periods, whether you have kids, how old you are when you have kids, whether you breastfed or do, that those are the kinds of things that you might be too old to change some of those. But again, these are all things that we know that turns out that having kids earlier actually lowers your risk. Having, you know, um, breastfeeding lowers your risk. Doesn't mean that you can't ever get a breast cancer. People are starting to understand a little bit more about the process of what happens when you stop weaning. There may be some things we can do to lower the risk so that we get rid of pregnancy-associated breast cancer. So that's kind of an exciting thing. But if you've had several biopsies, that usually means that you're someone who forms masses. Turns out on your mammogram that how dense the breast tissue is, meaning that the breast's made of fat, of sort of the ducts that carry the milk and the factories, the lobules that make the milk. So all these things and kind of how it's connected together. So here is on the left a very fatty breast composed more of fat, and the second one they call scattered fibroglandular sort of tissue. So the pink stuff is kind of scattered, and 3 is so the third and the fourth one are dense. This is completely dense on the right, and what they call heterogeneous and homogeneously dense. But these are the trigger words they have in the mammogram. Another way to think of it is BI-RADS A, B, C, D. That's the little way in which we look at it. So if you have very dense breast tissue, it's also possible that it's hard to see a tumor because the tumor can have the same density as your background tissue. And so either the ultrasound waves or the x-rays don't go through the tissue, and it kind of looks kind of white. So it reflects back the waves and it doesn't pass through. So that's what thing is, just because you're dense doesn't mean you're going to get breast cancer, but it does contribute to the risk. If you add several of these issues like dense breast tissue and family history, that may put you more at risk. And there are some risk factors that combined together indicate that you might benefit a lot from lowering your risk. So not everybody needs to take it, but there may be 5 or 10% of the population that would really, really benefit from these things. You know what it's like? I always like to say that, when I started practicing in the 90s, the late 80s and early 90s, the chance of dying of heart disease was at least 2 times higher than your chance of dying of breast cancer. It's actually now no longer true. And even though we've reduced the chance of dying of breast cancer, the cardiologists, the heart doctors, the whole field made it so that the chance of dying of heart disease is way lower. And how did they do that? They did it because they said, look, we're going to really understand what leads to heart disease. They started in the late 40s with this study called the Framingham study. And they figured out that high blood pressure and high cholesterol and overweight made a big, in smoking, they made all these big contributions to making risk. And then people started figuring out, oh, well, what happens if I start lowering these things? Getting people to, have better diet, better health, but more importantly, getting their blood pressure under control and getting their cholesterol under control. So there's medications called statins. Many of you may be on one, simvastatin, atorvastatin, this or that statin. These things drop the chance of getting a heart disease or a stroke by half. If you've got family history of stroke or heart disease, you should, in your 40s or 50s, you should be thinking, gosh, I should be thinking about a statin. What we want to do in breast cancer is have the same thing. We're starting to really understand the factors that cause breast cancer. Density is one of those things. We know we can change the breast density by medications like tamoxifen, and you can take it at a much lower dose. Used to be the standard dose is 20 milligrams, and we know that 5 milligrams works just as well. These are things that can change the condition and also make it easier to image the breast and make the mammograms more effective. Now, I'm not a big fan of doing ultrasound if you have very dense breast tissue. I think it's not a great screening test. If you actually have dense breast tissue and you're at higher risk, then some kind of contrast-based study like an MRI is going to be important. Now, there are other things that people hear about, 2D, 3D mammography. 3D is sort of being able to do multiple slices instead of just 2 images through the breast. And it's made some difference, but it's not really the huge advance we'd hoped it was. And it's not, for example, as good as MRI if you really are at high risk. But if you're not really at high risk, it's better than using MRI because you don't have the same chance of finding things that turn out not to be anything. Now, the idea of thermography, it's kind of a cool idea that you could, it's kind of some of the technology we use to look at suitcases and look through cracks in important materials that you're using for building. And so the heat sensitivity was going to be one of those things that really made a difference. And it turned out they did this big study. Actually, my sister's a mammographer and she was involved in it. It turns out that when they found something on thermography, there was a 50-50 chance that it was a cancer. And if they didn't find something, there was a 50-50 chance that there wasn't anything. So it really turned out not to be very good. They've done some big studies. It's too bad because it's a good idea and it doesn't require squishing the breasts, but it's not something that adds it. It's not covered by insurance. It'll cost you a bunch of money. And I'm sure you guys could probably find better things to spend your money on. So I think it's really important to know your density. And you might say, well, gosh, who's going to do all this? Who's going to help me understand my risk? No one's going to spend the resources and help me do that. But it turns out that is not true because you can join the wisdom study because we want to invest in you. And you can join the wisdom study and if you want to get annual screening and that's important, you can get that. If you want to get the personalized arm where we're looking at your background genetics or other things, you can join that. And if you say, well, gosh, I don't know, then agree to be randomized, let us learn. And as we learn, we're going to start changing. After 2 or 3 years, we're going to put in the next best thing and invite the cohort back to participate. And what we hope is the next generation of ways to screen better and smarter.
That's great. And I just turning back to sort of like some of these know your risk pieces, which again, like wisdom is absolutely doing. One thing I want to know with density, I mean, this is something that in many states, including California, is on your mammogram letter now. So this is thanks to advocacy, thanks to broad scale advocacy by a lot of folks. And same thing with a lot of the resources that Dee mentioned that are in the chat. There's been a lot of advocacy in this space. You do have a right, sort of, if you're getting a mammography, if you're getting a mammogram, to know your breast density. That's something you can have. Z, I wonder if you want to chime in here. I know a lot of folks have strong opinions on things like what kind of screening modality they want. How should you approach those conversations with your doctor? If you really think a 3D mammogram could be good, if you're interested in something like an MRI or something else, if you want to just better understand your risk, what are those conversations like, or how can someone raise that with their provider? Who should they raise that with?
Well, again, it depends on the education that the patient has around advocacy. I'm just going to continue to say that. And also, it also depends on their insurance. For example, I'm at an institution and we don't have 3D mammography. And depending upon what the patient's insurance is, where that 3D mammography may be performed, they may or may not have insurance that will cover it. So there are so many things.
Don't pay for it out of pocket. It is
Right.
not worth it. Do not do it. If they don't cover it, don't pay for it, because it's the most important thing is having a good mammographer.
Yes.
Not worth paying out of pocket for.
How
But
do you know if you have a good mammographer?
Well, that's a good question. You should go to a place that actually has someone who specializes in mammography. You don't want someone reading your mammogram who's basically reading the chest x-rays.
mhm,
And you can, that is a great question, Jen.
mhm,
Right, to advocate, who reads the mammograms here?
mhm.
Is there someone who really is trained in doing mammography? Because if it's the person reading chest x-rays, I would try and go someplace else. And as Z said earlier, there's BCCCP, there's lots of resources where you can get a mammogram. And right, where you can get worked
Mhm.
up, right, Z?
Yes, there are.
That are good.
But what I'd like to stress is something that I have to say UCSF does top notch, is education. Because self-advocacy is it's organic. It's gonna continue. It's not gonna, if you start being a self-advocate for your health, it is not gonna stay in the screening, the diagnostic realm. That's gonna be in your treatment, that's gonna be for clinical trials. That your self-advocacy, we should invest in that advocacy and making sure that you know how for the entirety of your care. It should go across the continuum. And if you start asking questions about screening and 3D mammographies, then it becomes a question of your insurance. That's more you have to know about your insurance. And there are just things that it overwhelms the patient. Just being overwhelmed because it's so large. And to the extent that you may want to be a self-advocate. You want to double check everything. You want to know that you have the right and access to a second opinion. There are so many things. So I feel that education is a good confidence builder, and it is also a good supplement when you don't have the confidence, but you can where to reach out to get that education. And I would say if we should really let more people know about the work that's done here at UCSF, because they have, the work is fantastic in all the different pamphlets, whether it's clinical, non-clinical, it's just amazing. The wisdom study, knowing that you have a place to go. So I would continue to keep the focus in on education as a form of developing self-advocacy and helping it to be sustained throughout the continuum of the care, and really try to put things in place to assist the patient on that self-advocacy journey. Like have some place that the patient can go when they have questions, that you can sit down, you treat it like a financial appointment. What is it that you need to know, sweetheart, in order to make you feel really confident in your self-advocacy? Have videos available that show the various ways in which you can become effective at being a self-advocate. These are the type of things that patients want to know. Well, where do I go to find that out?
Yeah, and go to the websites of places that you trust. We're actually in the process of totally revamping our website, but in another month, 6 weeks, we'll have our whole new website finished. And on that website, it doesn't matter whether you're a patient at our place or not. It has tons of resource for what do you do at this setting or not. This is actually, know your pathology is one of the things that, how do you read a pathology report? What's in it? How do you interpret it? What is it that they're looking for? And it's kind of an easy way to learn more about your pathology report. And we actually have this series available. It's for free. It was the folks at Genentech actually, paid to do to just do this educational program, which was great. And it just really, I think, helps everybody know what are the key things that I should know about my pathology report. And it's not, doesn't tell you about what treatment to get, but it just tells you these are the pieces of information that if you go to a good place to get treated, they will want to know your pathology. They will want to look at it themselves because these are the things that help them determine what's going to happen to you. As well, you know, there's a bunch of new contests that specifically look at new features about biology, but these are important pieces of information. You can go, you know, a lot of the major cancer centers have information on their sites. You know, when you go to the internet, it is really important to think about the source, right? See, I mean,
Yes, it is.
there is a ton of information out there, and a lot of it is nonsense. A lot of it is not that helpful. So you got to say, where does this come from? And how do I know that this is true, right? So you got to think about where is the resource and what kind of educational materials are there. And, you know, smart people can disagree about the same pieces of information, that there are some places that are more aggressive and kind of treat everything to the max, and there's some places that are a lot less aggressive and are always looking for ways to do a little bit less. I mean, I fall in that spectrum, but some of my colleagues who are very smart and really great physicians, you know, don't want to take any risk. And I always say that one of the most important things to know about opinions from physicians is that opinions from physicians reflect their threshold for intervention. So if someone's super risk averse and they're very afraid of something bad happening, they're going to recommend more. And, you know, the thing about it is you have to try and get the information in a way that helps you to remember that, you know, sometimes decisions are, should I get chemotherapy? Should I get radiation therapy? Some of these things are a little bit on the bubble. Well, you could get it, or maybe you don't. Maybe it makes a difference of 2 to 3%. To someone else, that's like, oh my God, of course, why would I not do it? And another person would say, are you kidding me? That's all? I'm going to do all that for that? People have different thresholds. And quite frankly, we really need to honor and respect our patients and sort of where they're coming from and what's important to them. Someone who, you know, has a reconstruction and, you know, and is then has a mastectomy and a reconstruction, and then they're told, well, you know, maybe you need some radiation, you know, well, I'm not sure, but it could help. Let's just do it. But then you say, well, is there any downside to that? Well, if I've just had a mastectomy and a reconstruction, does that increase my chance of having a complication from the radiation? And the answer is yes. And maybe it's not 100%, it's maybe 15%. But maybe if there's hardly any benefit, you might say, well, gosh, why would I do that? I don't want to take that risk. Or someone else might say, listen, honestly, I don't care about the reconstruction. What I want is to leave no stone unturned, because that's what's going to make me sleep at night. So why am I telling you all this? I'm telling you this because you have to advocate for yourself. I'm a big proponent of shared decision making. I see that people who feel browbeaten or told that they have to do something that they really didn't want to do just feel bad about it. And they feel bad about it for years. But if you actually understand, well, these are choices, these are options, the outcomes are a little different. Maybe you have a little bit less risk of recurrence, but a lot more risk of a complication that might actually be something you care a lot about. Or maybe it's just something you don't care that much about, and every little bit would makes a difference, and that's what makes you sleep. You've got to know what's important to you and advocate for what matters to you. Physicians
such a
should
good
be
point,
willing
Laura.
to have a conversation and work with you on that. And I really, that's how I practice. And I know that everybody doesn't practice that way, but when they get asked and approached that way, I said, look, here are my concerns. Here are the things that I worry about. Maybe this doesn't matter that much to me, but this really matters to me. Bring someone to listen with you. Ask if you can record the conversation. If they don't let you record the conversation, go someplace else if you can, because you're going to go home and listen to it. And one of the things that we also know is that when you're scared and when you're frightened, this is what you hear. La, 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 la. You hear the word cancer, la, 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 la. We know that. make somebody stop, take a
And
deep breath,
yeah.
and say, wow, I'm just feeling a little overwhelmed. I need to take a pause here and just get this together. We have a program called Question Listing. Um, and, it's something, it's a service that I wish everybody had, but you can also do it for yourself or get someone to do it for you and say, here, I'm going to make a list of the really important questions.
Mm-hmm.
And then make a list of it. And when you go in the room with your physician, don't think about this as some person who knows everything, whatever's going to tell you what to do. Go into that room and say, I'm getting a consultation to help me make sure that I feel good about the choices that I'm going to make, because that's going to be what helps me sleep at night and feel good about it. And that I'm going to help my physician by starting out by saying, you know what, before we start, I made a series of questions that are on my mind, and I wanted you to know what they are, so that when we have this conversation, you can think about it and make sure that you're addressing those questions. Now, most physicians will say, oh, sure, let me see what those questions are.
Mm-hmm.
And again, if they don't, say, I really want you to make, I want to, well, okay, well, let's come back to them then at the end, and let's make sure that we've gone through them, because that's what's important to me. I'd love to record this conversation because it's going to be hard for me to hear. I don't want to take notes. I'm going to try and pay attention, but I can go home and I can listen to it, and that makes me feel good.
Yes.
Most people will say fine, and there's lots of easy ways you can just record it on your phone.
Mm-hmm. And they also have apps where you can record it, specific apps for that type of transcription. And also self-advocacy also means not making a decision unless it's life-threatening prior to when you're ready. Or we want to hurry up and schedule. I haven't had time to really take this before my family. I'm not sure if I want to have a second opinion. So it's really just, again, providing patients with all their options up front, because it's hard to ask what you don't know to ask. And then, and for patients not to feel stigmatized by asking the doctors to please explain this to me in layman terms as best you can. Because oftentimes patients are reluctant to ask questions because of the clinical nature. And there are parts you can't get around. It's just going to be what it's going to be. But to have that discussion in a way that's more conversant and that invites even more questions, because when you speak to a patient that way and it's more conversant, and there are terms that you're using that are also in layman's terms, it invites self-advocacy through the form of relationship building. Everything shouldn't be a Q&A. Something should just happen organically because you're developing that relationship with your patient. So that's self-advocacy. They feel more empowered to ask and to receive the answers. So again, there are a variance of ways in which a patient can self-advocate for themselves. And I think the more we have processes and physicians that have the time to have those kind of relationship building conversations with the patient, that self-advocacy will come as a natural outgrowth, because they feel like there was someone who they can trust and who actually has their I won't say best interest, because I believe all doctors have their best interest, but they're educating them. They're invested in educating the patient.
Right. And again, bringing someone to the appointment, it's, you could advocate for yourself also, to say, I want to bring someone to my appointment. That was one of the things that really bothered me about COVID, is that, we always had people come to appointments with people. And so then that kind of stopped and the door kind of closed to that. But you can do that with someone on the phone. You can add, so I have my friend. Don't be afraid to say, oh, excuse me, can I get my sister on the phone? Or can I get my mom on the phone, or my daughter on the phone, or whoever it is, But now, I mean, COVID is really not the kind of threat it was before. And you can say, look, I really feel it's important for me to have someone in the room with me. I want to have someone in the room with me. That again, as he said, learn to advocate for yourself, ask for what you need. The worst they can say is no, right? And one of the things that we try and do,
and they shouldn't, right? I mean, I think somebody said this before, if they won't let you record, if they're reticent to find a way for you to have a voice in the room, I think it's another important thing that I think Z spoke to as well. Like, are there ways to find other doctors, or how do you need to know who else can be in the
Yeah.
room? Can you ask if there's a navigator available?
Yeah.
And it's so
Right.
challenging depending on where you're getting care. Not everyone can do
And
that.
And one thing to just to
this is your-
piggyback on what Dr. Esserman is saying is about having a person in the room. And I'm sorry, you guys, if I seem redundant or very insistent, but I've spent 10 years working in a safety net integrated hospital system, and the choices are different. But ask if they can have the person come in the room via Zoom. The reason why I say that is because I have had patients where they can't get off work, or their spouse or whomever they were gonna bring, they can't get off work, meaning they have enough time to get to the appointment, stay at the appointment, and get back to work. So depending upon when that appointment is scheduled, Zoom may be an alternative. If they have a 30-minute lunch and it's right smack in the middle of your appointment, we may be able to accommodate that by allowing that person whom they wish to bring into the visit be a part of it via Zoom. So, ask that question. Can I bring them in via Zoom?
Important.
Yeah, bring them in on the phone. And think of it this way. Think of it this way, guys. You're actually helping to make the healthcare system better, because you're teaching physicians that it's important to you as a patient to be listened to, and to make sure that you have people there who can help understand and ask questions for you, even if you feel intimidated yourself or overwhelmed. And that forces everyone to think about it differently. And that's when you demand it, that's how you get change.
Which I've been thinking something so similar, and it's so hard. I feel like so much of things that are being raised are things that should be built in. Like, your family should easily be able to get time off from their job to go with you to an appointment. That should be something we have in our society. Like, we don't have paid time off in our society. Like, you should easily be able to get second opinions. You should easily be able to find someone who needs care. Like, all of this stuff is so necessary. And in many ways, self-advocacy is filling in the gaps that exist in our healthcare system, right? Your doctor should invite you. What is important to you in your care? What are your priorities? Tell me about that. But your doctor might not, so you have to do it, right? And I think the other thing I think is just so important that I'm thinking about is, like, as you're learning to advocate for yourself, like, then make that phone call to your legislator and say, hi, I'd like universal health care so that everyone has access. We need more resources for people. So all of this forms of advocacy are so tied together.
Yeah.
We have
I'm sorry, Jen.
in the chat. Yeah.
I just want to say legislative advocacy is a real thing.
Yes.
And I am so glad that you brought that up. So yeah,
And we have
legislative advocacy
on our website. Actually, Allison, we can send this as a resource. Jeff Belcora and I've worked together for over 30 years, and we have this whole business of we've organized the whole way of doing question listing. But I think that's the resource, Rajna, that you just put in the chat.
Yep, correct.
Yeah, which is the possible questions to ask your doctor. So, most of the questions people have thought of before. So go to that question list and say, hey, what matters to me? And you know what? Don't be afraid to say, you know what? I've got a wedding coming up. It's my daughter's wedding in like 3 months. Am I going to lose my hair? Or like, this is so important to me. This trip I've been waiting for 5 years. I want to go on. Is there any way? Because you'd be surprised people can work backwards into it. If they don't know it's an issue for you, how can they help you? How can they make it a priority? And the thing is, you can do things safely and still make accommodations for what matters to people, right?
And Laura, so what you just mentioned, the tool and the resource for Jeff Belcora. So we just put together a breast health resource guide, and it's now just posted to the website. A lot of the topics that we talked about today are in there. We've heard new ones. We'll continue to update this document, this resource guide. We're hoping that it's helpful, not only as a way to remind people about some of the ways in which you can advocate for yourself, but also provide some resources, whether it's from other community organizations, national organizations, things like that. The programs that Z mentioned around breast cancer screening, coverage, if you don't have insurance, all of those things are in this resource guide. There's just a couple of pages here from that guide, what it looks like, that is now available to everyone. And again, if you have topics or areas that you think we've missed, please let us know. This is sort of a living document that we'd love to continue to make useful for everyone.
And you should connect up
Allison,
with
is the link live yet, or will we share that?
It is. It just went live.
Put it in the chat.
I can copy it. We can put it in the chat. And then also to note the breast health.
Can you also just tell Sarah Golden to make sure, so we have that link to our website we have, because you can also then be able to link to our website and,
Yep.
and should I talk about the breast health decisions tool?
Yeah, I think we have a few minutes. Yeah.
Okay, so we one of the things that really makes me sad is that if someone really is at risk for breast cancer and they are at risk for a hormone positive breast cancer, we now have tools. There are things we can do to help people lower their risk, and lowering your risk is more important than screening, actually. Because what if you could drop your risk in half? And there are things you can do to lower your risk, from lifestyle choices, like limiting the amount of alcohol you have, making sure you don't take postmenopausal hormone replacement, especially progesterone, you know, getting more exercise, changing your diet, eating, more plant-based diet. And if you really do have high risk and you're at risk for getting a hormone positive breast cancer, actually, it's really important because, there are medicines you can take, like the statins. Like, remember, we talked about reducing your cholesterol, your blood pressure. There are things that can drop your breast cancer risk in half or by 60%. And, the thing about it is they're all relatively safe. If you don't like them, you quit. But how do you know you don't like them until you yourself have tried it and see how it impacts you? And these are things that there's, maybe 10% of the people really would benefit. But you got to know your risk, learn something about it. That's one of the tools that we have on the Wisdom website. And so one of our goals in running the trial is to get better and better and better at figuring out who's at risk and for what type of cancer, so that we can really make prevention a priority. I want to be able to say in 5 or 10 years that, like the cardiologist, we have dropped the chance of getting breast cancer in half. We haven't done anything to touch that number, but we can do it. And I feel like this is something that the time has come, and there are things, and if the more educated people are and know that these are their options, the better off we're all going to be. Let's see, there's a question. Do you think the breast cancer models that show the field for tumors are good enough for us? You mean the models that sort of show what to, the little breast models where you feel a lump or this, that, and the other? I think so. And the thing you can do is, does it feel different on my side versus another one on the other side? And remember still that most things that you find on a mammogram when you get called back for it are not cancer. And there's no point in worrying about it till it's actually true, because until you know what it is and what you're doing, there isn't anything you can do about it. And, breast cancer feels like an emergency. It just feels like an emergency. It feels terrible. But the truth of the matter is, it's not days and weeks that you have months to figure out what to do. And, we want to get people treated in, a month or 6 weeks or something, but your life isn't on the line if you don't get treated right away. It's so important to learn about your diagnosis and to learn what to do, and more about the type of tumor you have and understand your options, or to learn whether or not you have risk. These are the things that you can do to take control of your health.
That's such a great summary and place to wrap up. We're right at the end of our time. I think a poll is going to launch in just a second for folks to share what they want to hear back about in future calls. I was just scanning through. I think I saw one other question I think we answered, which someone asked if an MRI requires a physician's referral, which it does. You do need to have a referral for that. If folks have other questions they want to pose, other things they think we should know, put in this resource guide, please feel free to share in the chat or reach out via email. And I don't know if we have more slides talking about our next one. I think usually these fall on the last Monday. We switched this one because of Halloween. Next month is Thanksgiving. So you may have to look out for emails for our schedule of events. But in the meantime, you can share the gift of wisdom. I think there's another upcoming event that we might have a slide about we wanted to promote.
Yeah, I just wanted to share, this event. This is on Saturday in Oakland, California, if you're in the area, at Jack London Square. Our partners at the Women's Cancer Resource Center, Dolores Moorhead and others, will be there, as well as others from the Tiger Lily Foundation, which was mentioned earlier today. So it's a 1 to 4 with lots of fun breast cancer related resources and activities. And then I also wanted to show a couple of new materials that you may see out and about on billboards and other places around the Bay Area if you're here. This is put out by Emoja Health, and it showcases one of our Wisdom Community Leadership Board members, Marion Harris. Beautiful pictures of Marion, so just wanted to share these, and if you see them out, you can give her a wave as you're driving by.
But remember, screening saves lives, but screening smarter is likely to save more lives and cause less harm. So join us at Wisdom and help us figure out a better way forward.
Thank you, everyone, so much. Thanks so much
Thank
to our
you.
panelists. Thank Laura. Thank you, Z. This has been wonderful. I hope everyone got some tools for advocating for yourself and others. And we will make sure we share all the information about resources, things to know in some mechanism, I hope, so that people can take these forward as they engage in good breast health. Thanks
Great.
all.
Well, thank you,
Thank you,
Jen,
thank
and
you.
thanks, Z, as always. All right.
Thank you, Dr. Esserman.
Thanks, everyone.
Thank
Take
you.
care.
Bye-bye.
Bye.